Hello and a warm afternoon. Good afternoon to everybody who's joining us today. It's the top of the hour, and we're going to give our attendees a couple more minutes to join us. As you know, the presentation today is about MACRA, this new upcoming law that is going into effect at the beginning of next year. This is going to be a beginner's guide to new reimbursement models, which means there might be information here which you've already encountered or looked at. This is going to be a series of webinars where we're going to go into additional detail with respect to the specific tracks under MACRA that you could apply towards and the pros and cons of going into each track. There's a lot of detail, and since this is a law that was only finalized very recently, some details are still being made available by CMS and by HHS. So we're incorporating them into our body of knowledge as they become available. Some of you have spoken to me personally. We've worked together. I have been here at CureMD for a number of years, and currently we have our fingers in many pies. So it's an exciting time to be in the healthcare industry. And specifically at this time, we're working on the new advanced alternative payment models that are being released by CMS, how we're going to proceed towards them. And today is going to lead up to that. So just for everybody who is going to have a question during our presentation, the GoToMeeting toolbar on your screen, it has a question and answer section where you can paste your question. We have a lot of content to go through today, so we may not be able to take many questions during the presentation, but we will be answering every single one and placing the questions and answers on our wiki page. So if you have not had a chance to look at it, CureMD, within the application, within the help menu, there's a wiki section especially for MACRA, including tutorials and some videos showing you how to go about working towards MACRA and how to succeed in MACRA. So I think we're going to get started, and we're just going to start working through the agenda for today. So we want to talk about what MACRA is, and every time a new legislation or a new law comes into being, especially in the healthcare industry, there seems to be a number of abbreviations and new terminology that comes into play. And so we're going to talk a little bit about what some of these terms mean. And with the recent elections and with President-elect Donald Trump committing to making some changes in the healthcare industry, we want to talk about what happens to the MACRA law over the next couple of years. Then we'll go into the quality payment program under MACRA and possible incentives and penalties. So that's a recurring theme in how CMS has been promoting some of their agenda. So they want to push practices towards achieving something, and a combination of incentives and penalties encourages that. And then we're going to talk about here's some abbreviations: MIPS, APMs, and advanced APMs, and what those are, what they mean for you in your practice. And then we can start talking about what is the right track for you. There are dependencies if you are a smaller practice or a larger practice, whether you're already working with an alternative payment model or within an alternative payment model, whether you're already set up to pursue that track from the get-go, or you want to phase in to some of these new requirements that are coming up. We will touch on critical deadlines, things that you need to do and when you need to do those by. And lastly, we'll give you a checklist of things to do under MACRA that will help ensure your success. So a lot of this is going to be with respect to next year, 2017. That's when all of this kicks off, and that's where we're going to get an understanding of how this affects us. So right now, a lot of this is up in the air. There are rules and there are projections, and there's an idea of how this is going to affect practices, but we're not going to have confirmation of a lot of that until maybe mid of next year when some of these reports start coming out. So let's begin. What is MACRA? It took 2 years of work to finalize MACRA, and it was signed into law in April 2015. The basic ideas behind MACRA are a combination of things that CMS has been doing over the last decade. And actually, some of the core ideas behind MACRA come from a Republican politician who proposed them about 10 years ago. So what MACRA does right away, or what it's done since 2015, is that it's extended the Child Health Insurance Program, the CHIP program, for 2 additional years, so funding for that has been provided. It requires Medicare to move away from Social Security-based ID numbers. So the Medicare ID that you see right now on patient ID cards, that is going to get changed, and a new ID number is going to be issued to the entire Medicare population. So that's a big undertaking in itself. It includes new funding for development and testing of performance measures. So the measures that you come across when you're looking at PQRS or other quality programs. These are constantly being developed, new measures, and then those measures are tested so that they're providing the right data to the government. And it creates new programs and requirements for data sharing. So you'll notice as we go through this series of webinars that a big focus is on coordination of care and sharing of information, getting information out of silos that each individual provider or practice maintains, and enabling other people to look at the data and combine it together into a coherent history of the patient or status of the patient. It establishes new federal and advisory groups to support this. But the bigger deal for medical providers is that it repeals the sustainable growth rate, so the SGR formula. And this is something from way back in 1997, which sort of decided how physicians would get paid every year. And its biggest impact that we saw was that every year, earlier in the year, there was a prediction that this year, due to the SGR, we're going to get a cut of 15, 20% to the Medicare fee schedule, and Congress had to sit down and delay that cut year after year after year because they had no better solution to the sustainable growth rate. And the sustainable growth rate in itself it was created so that you could control Medicare costs. So that kept happening, and up till last year, that percentage cut to the Medicare fee schedule was supposed to be around 25%. So MACRA got rid of the sustainable growth rate and replaced it with something called the Quality Payment Program. So this is the new way of, or the new model of reimbursement for Medicare providers. And one of the things that it does in comparison to the existing uncertainty about your fee schedule every year if you're a Medicare provider is that it starts off saying the first couple of years we're going to have a steady 0.5% increase in the Medicare fee schedule every year. So that's like clockwork. Every year, 0.5% increase in the Medicare fee schedule. So that's what MACRA is at its very basic. It's legislation, it's a law, and it resulted in what we know as the Quality Payment Program, which affects many of our providers, which affects everybody involved in this industry. So what happens to MACRA under the Trump administration? So far, everything that we've heard from President-elect Trump and his team points towards the fact that they're not going to change MACRA very much. There's been a lot of talk about the Affordable Care Act, and initially it was, it's going to be repealed, but there's been talk recently about, some of the portions of the Affordable Care Act being good and being the things that we need to keep. So there's a rollback to certain sections under the Affordable Care Act that's being proposed. But even to do those things, you need to, come up with new legislation, new ideas, and the plan is light on those details. So we don't know specifically what can be done, what can take place of the things that are happening under the Affordable Care Act. And MACRA is not exclusively tied to the Affordable Care Act. So it's going to remain in place even if the Affordable Care Act is rolled back. The other part about MACRA is that it has huge support. So it passed with almost unanimous support in both the House and the Senate. So politically, it's a law that everybody supports, everybody agrees to, and apart from politics, CMS spent the last 6 months or so after they initially released the proposed rule, getting comments and feedback from physician associations, from players in the healthcare industry, and they've taken those comments very positively, and they've made changes to the program that have brought physician associations on board, that have brought the healthcare industry on board, and a lot of investment, a lot of funding has gone into preparing for this change. So the change that is due to happen January 1st, 2017, this is part of the legislation. So the legislation required that this new quality payment program start running and be in place starting next year. So, but within that limitation that they had to start immediately, CMS made enough changes to get everybody to agree that this is something that they could do. So this is something that the whole industry could work with. So that's where we are. That's what we accept or expect to happen under MACRA. Next year, things will proceed as normal, as currently known to us. And the years after that, there might be subtle changes to portions of MACRA, but the bigger picture and the bigger idea remains in place. So what is the quality payment program? So this replacement to the SDR, this replacement to how physicians are going to be reimbursed. CMS has had this vision to improve quality, to improve care efficiency, but at the same time reduce cost. So those things seem to be opposites of each other, right? And what they've focused on in this era is that providers and practices should be focusing on the health of the population, and they should be coordinating care better amongst themselves. So one of the core or fundamental reasons that they think the costs are so high for healthcare is a lack of coordination. So the quality payment program goes into effect January 1st for providers who participate in Medicare Part B. So this is about some 600,000 providers. And this quality payment program also accomplishes another thing. So there's a number of different Medicare programs that are running in parallel. There's Meaningful Use. There's the Physician Quality Reporting System, PQRS. There's Value-Based Modifier, which is not so well known. And these are three distinct programs running under Medicare which are going to be combined and consolidated under the quality payment program. So everybody's going to be on the same page as to what they need to do and what CMS wants out of this entire program. So there are two tracks under the quality payment program, and the two tracks are called, the first one is abbreviated as MIPS, but that's the Merit-Based Incentive Payment System. So this is where we predict the majority of Medicare Part B providers will be in the first year in 2017. And then there's the advanced alternative payment models. So alternative payment models already exist, and there are advanced versions of this that are going to be the second option for practices. These advanced alternative payment models are where the MACRA legislation wants all providers to be in a number of years. So the regular payment model that we're following at this moment, where we talked about the Medicare physician fee schedule, is that you have services, you bill for services, and you get paid for certain services. The alternative payment models have or include things like bundled payments, capitations, shared savings. We're going to get into a lot more detail about that, but those are some of the basic things that happen under advanced alternative payment models. So the MIPS track is envisioned as a short-term, and by short-term we're talking about 3 to 5 years training ground to help practices learn how to successfully adopt advanced payment models. So one of the running themes in MACRA is that CMS is trying to align all of these different requirements and programs that they've been running and aim for a common goal. So aim for common reporting, aim for common quality measures. So they've made MIPS such that if you succeed at MIPS, you succeed in most of the requirements within an alternative payment model or advanced alternative payment model. And since an advanced alternative payment model has, in the longer term, a much better financial return, they expect that practices would automatically switch over and leave the MIPS or fee-for-service schedule behind. So this is the quality payment program in a nutshell, right? So there's the MIPS track, where you have a couple of different categories where they're going to look at your performance or look at providers' performance. And then we have the alternative payment model track, where we have ACOs and medical homes and bundled payments. And those we're going to get into detail or significant detail later on in the presentation. But the other upside of the quality payment program is that it actually reduces the amount of penalties that you were looking at starting 2019. So currently, we have the PQRS program running, we have the Meaningful Use program running, we have the Value-Based Modifier program running, and these in total, depending on whether you're a larger size practice, could be up to 10% in penalties. So there's a downside to not participating, not doing well in these programs. And that's a significant amount. For most practices, 10% is a big deal. And MACRA, or the quality payment program specifically under this, it reduces that initial starting point and says, okay, let's go back to 4%. Let's give everybody a chance to get on the same page. We're going to make it easier to participate in these programs. We're going to reduce the reporting burden. And we're going to give everybody a fair chance to get on the train so that we can all progress through MIPS successfully. So that 10% cut that you were looking at, or that you're looking at under the existing programs, that doesn't even include the 2% sequester. So there's a lot of money out there that people were losing. There was no upside. But now under MIPS and under the quality payment program, there is an upside. So there are potential bonuses that you can earn, as opposed to just look at penalties and just the only thing that you get out of participation is that you don't get penalized. So that's the quality payment program. Under MACRA, which was a law or legislation, CMS created a payment model or a reimbursement model called the quality payment program. The quality payment program, on most counts, is very good news. So it solves the SGR problem. It gives you a stable payment update for the next 5 to 10 years. It clarifies what CMS reimbursement policy is going to be for the next decade. It reduces penalties and adds new incentives which weren't there before. It consolidates all the existing programs that Medicare was running. And it makes participation easier. So it actually reduces the requirements that you had to participate in these programs. So all the things that have been happening over the past 5 to 10 years. So meaningful use, it pushed providers to start using certified or electronic health records that provided data to CMS and Medicare. PQRS, again, these were measuring quality and forcing you to report data to CMS and Medicare. Then the value-based modifier, which took how much you were costing the Medicare program into account. And then, of course, ICD-10, which allows Medicare or CMS to better understand what kinds of patients you're treating. All of that feeds into, so all of that went into QPP, into the quality payment program as a thought process. And this is the result. So everybody's on board. We understand what it is. The legislation makes sense. How is it going to be implemented? And we talked about those two tracks. One was the merit-based incentive payment system, MIPS, and the other was APM. So we're going to start off with the merit-based incentive payment system. So 90% of providers will end up in this portion or in this track under the quality payment program in 2017. Providers are going to be scored across 4 categories on a scale of 0 to 100. So this, and in 2017, the 4 categories are quality, which is basically PQRS, but with reduced requirements. Then there's improvement activities, which is a category focusing on care coordination. It borrows a lot of requirements and measures from the patient-centered medical home concept. Then we have a category called advancing care information, which is meaningful use, but again made easier to work with. And then we have the cost category, which is a replacement of the value-based modifier category. And this is where Medicare judges you on how much money you're spending on beneficiaries and whether you're costing them more per beneficiary as compared to other physicians in the same region, in the same specialty. So these are the 4 categories, and in 2017, the quality category, which is the PQRS piece, it accounts for 60% of the score. Then we have the advancing care information category, which is meaningful use. That accounts for 25% of the score, so a quarter for meaningful use. And 15% for the third category, the new category called improvement activities, which is where you take up a couple of activities to change processes or improve processes in the clinic or in the practice, and you attest to doing so for 90 days or more. And the last category, the cost factor, is something that initially for the first year is going to be excluded from the calculation, but Medicare is going to be reviewing or collecting data on each practice. They're going to be providing feedback, and they want you to be using that feedback so that you're prepared. Cost is going to become a bigger and bigger piece of this total score that providers are going to get. There are exemptions from the merit-based incentive payment system. So if you're already a part of an advanced alternative payment model, you're exempted. You don't have to participate. You don't have to submit this data, and you're not going to be judged on the score. If you're in the first year with Medicare Part B, again, you have that exemption so that you can transition over into the program. If you have low volume, so you have less than 100 Medicare patients that you work with, or you bill Medicare less than $30,000 in allowable charges, then again, you have an exemption. But another thing that you'll come to notice is CMS is trying to involve the industry on a much larger scale this time around. So not only are they opening this program, the Merit-Based Incentive Payment System, to private payers in about 2 years, they're also asking the private care industry to jump on board even sooner than that and run parallel programs. So for many, many years, Blue Cross Blue Shield has been running their own programs to judge physician quality in parallel with PQRS, sometimes even using the same measures. There are some state-specific requirements from certain payers where they're asking providers to collect data and providing incentives for that data collection. So the private care industry or the private insurance industry is on board. They're pursuing the same thought process, the same strategy, and they're looking at the same problems in general. Healthcare cost is rising. You can't keep charging patients more and more, so there has to be a middle ground. There has to be a way to scale costs back. Right, so let's talk about timelines for the merit-based incentive payment system. And this works very similar to how PQRS used to work or the value-based modifier used to work. So next year, 2017, is going to be a performance year, and you're going to collect data through whatever period of that year that you start working with MIPS on. And March 31st of the next year, in 2018, you're going to submit that data to Medicare. They're going to process that information, come up with the results, and provide feedback. And all the payments that you start receiving in January 1st, 2019, or starting January 1st, 2019, they're going to have that adjustment applied, whether positive or negative, to your base Medicare fee, and that's going to be caused by the performance that you have next year. So it really begins right away. Now, let's jump through this very quickly. What Medicare found, or what CMS found out when they published the initial rule back in April, was that everybody had an opinion about, how quickly, and it was almost unanimous opinions with respect to how quickly this program was, being put into place, and providers were basically being forced to join in without a lot of understanding, without time to prepare for MIPS. Their argument on some levels was that you've been doing a lot of these things in the past. This is not entirely something new, but with respect to the fact that a lot of practices maybe did not join in to meaningful use, or have not converted to electronic medical records, or do not have sufficient experience with PQRS, they came up with 4 different ways of you to participate in the first year. So this was called the pick your own pace option, and practices can choose to submit no data. And we're saying that's a bad idea, and we're going to explain why, but that's going to cause a 4% penalty when you start receiving payments in 2019. Or you submit minimal data. That means you report at least information on one measure in PQRS. So it's very, very basic requirements just to prepare you or get you in the flow of submitting this information. And that will result in you getting no penalties at all, but no bonuses either. Or you can submit data for a 90-day period within the year. So you can choose to begin as late as October 1st of 2017, so 3/4 of the way through next year. And if you submit enough information, and if the number of people who are not submitting data for the entire year is not that huge, you could qualify for an incentive. So there's chances that you could get an incentive, and that's still being worked on. And the last option, of course, is to submit all the data that's required for the entire year, be guaranteed an incentive, and additional bonuses, which we'll come to in just a bit. So another cool thing about this is not only are the programs fairly similar to what we've been doing or working with before, but the submission methods are fairly similar. So if you submitted data via claims for PQRS, or if you did it via registry, that still is an option. Although for PQRS, or the quality category in particular, Medicare has closed that loophole where you could submit data for just 20 patients via registry. So you don't have to submit data for your entire patient population, or I think the threshold is 50% of your patient volume. So they have taken that very easy way away from practices. You can't submit data on just those few patients. It does have to be on the majority of your patient population. And then the other thing that we know is that those weightages assigned to those categories, they change every year. So the cost component, which initially counts for, or is not included in part of the calculation, it counts for more and more until it gets up to about 30%. So a third of the score, almost a third of the score, is going to be based on how much you're costing the Medicare program. And then there are reduced requirements for hospitals or non-patient facing clinicians. So if you're working in the lab or you're a radiology technician where you don't have maybe patient face-to-face contact a lot, you're not billing those codes, or rural practices or FQHCs or RHCs, they have much reduced or minimal requirements under this program. And then every practice that has less than 15 physicians, that's considered a small practice, and so their reporting burden is reduced further. So once we get into our next couple of webinars where we talk about specific categories under MIPS, so the small practices get, to do less work and be counted the same as larger practices. So a way to balance maybe the two sides where larger practices have an inherent advantage of more funding, more resources. So they're trying to balance the books in those cases. And CMS has come out again and said that we're going to make, or do everything in our power to ensure that small practices have a fair opportunity, a fair chance of both earning the incentives and qualifying for advanced alternate payment models. So that's the MIPS incentive payment system, but how does it affect you? What's the financial up and down for or under this program? So before we get into, and I have a nice graph to share with you, we're saying that there's a bonus that's assigned to physicians every year, and there's an equivalent penalty if you don't participate well or you don't do well under MIPS. But there is a high performance bonus which comes from a separate budget. I think the budget is about $500 million over 5 years. And this is a 10% bonus that you get if you're part of the top 10% of MIPS providers. So if you score that highly, and again, if you're doing very well with meaningful use and PQRs already, that's 85% of the score, right? So those two categories make up 85% of the score, and with the requirements getting easier or reduced under MIPS, you should be able to easily satisfy and achieve the majority of those scores. So if you're a top performer, and many practices choose, let's assume, not to participate or not to participate fully under MIPS, you're going to immediately be or you're going to have a chance to achieve this additional bonus of 10% apart from everything else. So the other thing about MIPS is that it's a revenue neutral program. What that means is that the bonuses that you get, apart from this 10% that we just discussed, have to come out. Those funds have to come from the penalties that are applied to other physicians. So the physicians who don't perform very well under MIPS are going to be paying the penalty, which is going to become the incentive for physicians and practices who do well. So Medicare, or this program, is strengthening those practices and physicians that do well based on their measures and based on their requirements, and all the practices that are not doing so well or not complying with those requirements, they're going to get financially, hamstrung. They're going to have less and less funding coming through compared to the top performers. So inherently, those people who are doing very well in these programs are going to have a huge head start, an advantage, and especially those who do well in the first year, because CMS is expecting a lot of practices or physicians to take up those exemptions and to pick their pace to not report anything but minimal data in the first year. So if you have a lot of physicians doing that, then the chances of you getting a exceptional performance bonus increases. So not only do you get scored under MIPS, but your scores and how well you're doing under the PQRS program, under quality, under meaningful use, these scores get published on a website. This website is by CMS. They're calling it Physician Compare, and they're making it a website similar to what patients would use to find you. So if you had a patient who had Aetna coverage, they would go on the Aetna website, they would put in their zip code, and they would look for physicians, or let's assume we're talking about a commercial website like ZocDoc. So patients would go onto the website, enter a zip code, and they would look for physician ratings. So now Medicare has their own rating system for physicians, and they're going to be publishing these ratings yearly, noting them on their website, and they're going to say, okay, well, here's a 4-star provider or practice because they're complying better with our measures compared to a 2-star practice. And for a lot of your patients, they may not know what those 4 stars really mean, but they're going to say, 4 stars is better than 2 stars, so they're going to pick that practice over the physicians who don't do so well. So that's another nuance of what they're trying to achieve with this program. They're trying to publish that data in a way that can be easily accessed by patients, and then, of course, those patients are going to start picking those practices and providers who achieve a higher score under MIPS. So we were talking about earlier about penalties and bonuses and incentives and exceptional performance, and it's not so simple this time around to say that if you don't participate, then you're looking at a 4% cut, and hey, maybe that's not a very big deal. But compared to the practices who are doing well, that is a really big deal, because if we look at just those initial numbers, just the penalty and the bonus, that's 4% down or 4% up. So you're looking at an 8% gap in the first year between the practices who do well versus the practices who don't do so well. There is a multiplier. So if there are a lot of people who don't perform well, then the funds from penalties will increase, and those funds have to be distributed amongst the people who are doing well. So that percentage, that 4% incentive, could increase to up to 3 times. So it could be as high as 12%. Not in the first year, again, because of pick your pace, but second year onwards, that could be a 15% bonus compared to a 5% penalty. Right? And that does not include the 10% in high performance bonuses that come from an entirely separate budget. So the difference between a practice that doesn't do so well, who lose 5%, and a practice that does very well and they get somewhere around 25% in bonuses, is a huge 30% in financial revenue. So that's a third of your revenue that's swinging one way or the other depending on how you perform under this program. And those percentages continue to increase all the way through 2022 when they stabilize at 9% and continue at 9% from then onwards. So on one hand, Medicare is increasing your fee schedule every year by 0.5%. There's a sequester which cuts out 2% of your payments, and then there's this swing anywhere between starting from, let's say, 8% to 10% to 14 to 20 to maybe 25% between the best practices and those who are not performing so well under this program. So that's MIPS, and that's how it's going to play out. So let's recap what we know about this program, which will apply to the majority of physicians starting next year. So 1, it combines the existing program's PQRS Meaningful Use Value-Based Modifier with a new program called Improvement Activities, and it combines and consolidates all of them, streamlines them, makes reporting requirements easier. Then across all of these 4 categories, it scores physicians to come up with a composite score based on weightage that we just talked about, and the results get published online. The incentives for the top performers come from penalties applied to the lower performers, and there are additional bonuses available to the best performing practices. And since PQRS and Meaningful Use are the biggest pieces in the first year, doing well in these categories is paramount. So either you've already begun and started working with these programs, or it's been a number of years, you've heard about them, you're on the fence about whether to implement or not to implement. This is going to be the key decision that you're going to make if you decide to participate under MIPS. Right. Okay, so we're going to now shift over, and we're going to talk about the other track, the other side of the fence, which is the alternative payment models. More specifically, advanced alternative payment models, but I want to start off with alternative payment models. And a lot of you would have heard about ACOs, so that's an example of what alternative payment models are, but that's just one type. So alternative payment models are models that deviate from traditional fee-for-service, right? And CMS has been experimenting and running pilot programs regarding these for many, many years. So even capitated payments or per member per month payments are a form of alternative payment models. So there would be a variation of the Medicare payment physician fee schedule, or so you could have a percentage of revenue coming from or reimbursement coming from the fee schedule and a percentage based on either incentives or penalties, or a brand new model altogether that scraps that and starts from scratch. So APMs require healthcare organizations to have a goal of taking care of a population of patients. So usually alternative payment models assign a set of patients, usually in the same geographic area, as a population that alternative payment model has to care for, or the entity that's following that model has to care for. And a lot of the larger alternative payment models, they have started working on, or they've started collecting, socioeconomic data, what kind of income levels their patients have, how much care do they get when they're young, when they're children, how that affects them when they grow older. So since you're responsible for the entire health of the patient, you're working through them across the majority of specialties, and at the end of the day, you have a target that's usually to provide high quality care and low cost care to that defined group of beneficiaries. So when we talk about ACOs, you have a set of patients and you have a target cost and you have a target quality level, and while maintaining that quality, you have to cut costs or you have to reduce spending, and the amount of spending that you're able to reduce below that target, you can share that with Medicare as savings. So those are Medicare savings, and Medicare calls this program the Medicare Shared Savings Program, and depending on the amount of risk you agree to take on, so in case you do not save any money but you overspend, then some of that additional overspending has to come out of your pocket as opposed to Medicare alone paying the bill or footing the bill for that. So if you decide to take on more risk, then Medicare decides to give you a higher percentage of the savings in case there are savings. So, and that's the aim of the program. So this image on the right sort of walks us through the different kinds of reimbursement models that you have. So under MIPS, you have the fee-for-service, and then you have the performance-based contracts, and then we're talking about alternative payment models, which are bundled payments or shared savings, and then we're talking about advanced alternative payment models, where we're saying take on some risk, share the risk, and global payments. So we're going to talk about those again in more detail today, and a lot more detail when we have a session specifically on the alternative payment models in the near future. So that's the progression. So we just mentioned alternative payment models. Now, what are advanced alternative payment models? So Medicare or CMS is aligning these alternative payment models with MIPS. So to be considered an advanced alternative payment model, participants need to be using certified EHR technology. So that becomes a base or core requirement. Under MIPS, this is the ACI category that you get graded against. So it makes sense that this should flow along into the next program that you would participate in. And if you're part of an advanced APM, then using certified EHR technology, at least across the majority of your provider population, that's a requirement. APM payments should be based on quality measures that are comparable to those quality measures under the MIPS quality performance category. So again, we're aligning the measures in the alternative payment model to the measures under MIPS. Then the third requirement is that the APM entity, the entity that uses an alternative payment model, needs to bear more than nominal risk. So the alternative payment models, such as ACOs that are available now, there are some cases where you take on no risk. So if there are savings, you share those savings with Medicare 50-50, and you get half of those savings, and that's your bonus. But if you lose money, then Medicare foots the bill for that entire loss. And so a program that does that, or a model that does that, cannot be considered an advanced alternative payment model, with the one exception of it being a patient-centered medical home or medical home model as expanded under the Center for Medicare and Medicaid Innovation Authority. So PCMH, or that designation, that's the one alternative care model that does not have to bear financial risk to be considered an advanced APM. So what's the advantage of being an advanced APM over being in MIPS, right? So you avoid the MIPS reporting requirements. You avoid getting those individual scores. You avoid having to submit that data individually. And in most cases, it's actually an avoidance of duplicate reporting, because you would not be doing that reporting on your own as an individual, but the APM entity, and usually alternative care models involve more than one practice. So the entity that's managing the entire ACO, for example, they would be the ones who are doing the reporting. And providers with a sufficient percentage of their Medicaid patients engaged in that model would receive a lump sum 5% bonus in addition to all the bonuses in the APM itself. So let's assume you billed Medicare last year and it was a couple of $100,000 in total revenue from Medicare. They will take 5% of that and present it to you this year upfront, no questions asked, and that's funding so that you can improve, so that you can invest in resources. So that's an upfront and additional payment that you get that is not tied to anything else. So that's one of the other advantages of being in an advanced payment model. So the downsides of being in an advanced payment model, of course, is the risk to revenue. So you carry a similar risk, and that risk depends on how well you perform on those measures, how well you perform against that cost target. So for a lot of practices, participating in an alternative payment model has been an iffy thing. There's not been enough data. You're not sure. There's not been good enough financial modeling to tell you, what that target is and whether that's achievable. But there are a huge number of practices and providers who are participating at this point, and we're slowly getting more and more information about how this plays out. So that's an option, and if you've implemented the basics, so if you've implemented processes, if you've implemented electronic health record technology, if you're sharing data between practices, one of the common things that they talk about is closing the referral loop. So you're tracking patients being referred to specialists and then tracking them back into your practice, obtaining that details about the referral, details about what happened during the referral, all of that. If you're doing those things, then the alternative payment model in the longer run is financially more viable than MIPS. So we're going to come back to that picture that we looked at earlier of the two models under advanced alternative payments. And so we talked about ACOs, that's the Medicare Shared Savings Program. Then there's the medical home. So under the medical home, there's a program for primary care physicians called a Comprehensive Primary Care Plus. That's a program that's rolling out, initially at least, applications to that program were closed, and that happened in September of this year, but CMS is opening up applications again, and while that is happening, or that participation is allowed only for practices in designated areas, but if you're within that area, that program is a bit of a combination of capitated payments plus fee-for-service plus additional bonuses if you achieve certain targets or certain criteria. Another type of alternative payment model is bundled payments. So if an example of that would be joint replacement surgeries. So what Medicare has done in the recent past for hip surgery and knee surgery is that they've taken groups of practices and physicians, all of whom are providing care to the patient during that episode of care, during that surgery, whatever happens prior to that surgery, rehab after the surgery, and as a group, they've designated a target cost, and they're saying, here's our cost for this entire episode. If you can beat the cost, then the savings are yours. We share them, or they're yours, but it has to apply to that entire set of practices and physicians who are working in that episode of care. So here's a listing of some of the models in 2017. We have the shared saving programs from before. So you notice track 2 and track 3 listed next to them. It was a track 1 under the Medicare Shared Savings Program, and that's the ACO that has no financial risk, no downside risk. So these two programs had downside risk, so they qualify as advanced alternative payment models. Then we have a next generation ACO model, which has even higher risk that's taken up by the practice or the entity, but it has even higher bonuses. Then we have a new program called Medicare Shared Savings Program Track 1 Plus. This is being intended for smaller practices to participate in, and what CMS has termed initially as virtual groups of practices. So you don't have to, actually group together. You can create virtual groups of practices who work together, share information together, and who apply to an alternative payment model together. Then you have Comprehensive Primary Care Plus, which we just talked about, and then specialty-specific models for end-stage renal disease, and then oncology care model, two-sided risk. And that's actually available in 2017. They have moved that forward from 2018, which was the initial go-live date for that model. So let's talk about what's the right track for your practice. again, we mentioned earlier, if you're already participating in an alternative care model and it qualifies as an advanced model, that probably is the way to go. You have the processes in place, you have the people in place, you have the resources in place to succeed. But otherwise, and if you haven't already participated in one of those models, advanced alternative payment models are only available to about 10% of all physicians, at least in 2017. So they're not available across the entire spectrum of specialties in all regions. So it may not be an option for you, right? And MIPS allows a very decent transition from the existing way of doing things under PQRS meaningful use value-based modifier to what would be very close to an alternative payment model. So you could spend a year or a couple of years working through MIPS and converting your practice from one that's used to working on the fee-for-service model to a practice that can take on some risk and can take on that added benefit of being part of an alternative payment model. The Pick Your Pace option makes it very easy to participate in MIPS without risk next year. So you get an entire year where you can go in and you can put in processes and you can judge how well they work out, and you can make changes. And let's say you find out halfway into the year that you really need to revamp, and once you do that, you still have that 90-day reporting option that gets you maybe some incentive, not just takes away the possible penalty, but gets you into the running for an incentive. So if you can excel at MIPS in the short term, it actually makes better sense, better financial sense, and I'll show you why. So this graph goes many, many years into the future, and we don't really want to, predict what's going to happen, but we want to look at, the baseline. So this is based on the 2015 fee schedule, and every year after 2015, we're getting that constant 0.5% increase in the Medicare fee schedule, the base fee schedule. And then starting 2019, we're going to start being judged under the MIPS program, so if we're in the MIPS program. And initially, at least, so this is the baseline where everybody's going to be if they have no penalties and they have no incentives. This is where they're going to end up. So a slight increase every year to the base fee schedule. What you're earning today in terms of revenue from Medicare or reimbursement from Medicare is only going to change very slightly if you have the same number of patients. It's just the yearly 0.5% increase. But let's say you're under MIPS, and immediately in the first year, there's that diversion. So either you go 4% down or you go 4% up. Then increases to 5%, then 7%, then 9%, which remains constant. And so that 18% gap between practices, that continues onwards, right? And that's under MIPS. Alternative payment models initially get a lump 5% bonus every year. This does not factor in the savings, so we don't know how well an alternative payment model will perform. You could earn, or you could be earning savings that are much, much higher than what's potentially available under MIPS. But what we do know is that if you do perform well under MIPS, and the variables for good performance under MIPS are fairly well understood. So you have PQRS, you have meaningful use, you have one other category that in the first year at least you're just attesting to. The cost category, you have a year to understand what services you provide that maybe make you cost higher than or as compared to your peers. So they are comparing you to other providers of the same specialty in the same geographic region. So if you have a lot of time to understand that, and if you are an exceptional performer, you're jumping way above what the average APM provider will be earning, at least in the first couple of years, until that additional bonus runs out. So maybe for the first couple of years, it makes sense for you, if you're not prepared and if you're not already in an alternative payment program, to jump into MIPS with both feet. Decide that we're gonna make this as our first target. This is going to be the goal that we want to achieve. We want to perform exceptionally well under this program. And afterwards, as we have seen based on the requirements for advanced alternative payment models, if you're doing well in MIPS, you can definitely do well in those programs. They lead into each other. So MIPS leads into APMs. So what do you need to do right now to do well, to excel under the MACRA rule? So first of all is education. You need to understand what's happening. You need to understand what your options are, whether or not there are alternative payment models that are available to you. And Medicare and CMS have created an excellent website with a lot of information that takes you through the basics to fairly advanced explanations of what's happening, and that's called the qpp.cms.gov website, Quality Payment Program. So that's your first resource, but there are tons of people doing webinars and very, very good webinars that you can look at, but you can always come back to us and we will consolidate that information and share that with you. You need to be looking at your QR/UR reports. So these are reports which Medicare shares with individual physicians. You have to log into your Medicare or PQRS website and obtain these reports. They're the quality and resource use reports, and they're feedback to you of how Medicare is evaluating you under PQRS and under the value-based modifier program. So they have been evaluating you even if you haven't been getting adjustments because of exemptions or practice size, or next year where that category accounts for 0% of the total score. But that will tell you where you stand under this category, which in a couple of years will become 30% of your MIPS score. So again, if you're already doing well under that category, that's already a great sign. You know, you got 3 of the 4 categories covered. All you need to do is to figure out what to do in the 4th, which is probably the smallest piece, and you can succeed in this program. The financial impact of this. So I would like you to be looking at both what it would cost you not to participate if you get a penalty, and what it would cost you in terms of lost incentive revenue. So there's a very, very big gap that shows up between practices that do well versus practices that either don't participate under MIPS or refuse to send any data or just don't do well. And that gap just gets larger and larger with time. So that means that even for the first year, for example, next year, if you choose to take it easy and you say, oh, you know what, I can pick my pace and I want to go really slow, you're going to be behind practices who are going to be better prepared, who are going to have experienced what it is to or how to do well under MIPS. They're going to have additional revenue, additional reimbursement that they can use to get resources, that they can use to improve their practices, improve their processes, and do even better come 2018. You need to be talking to your meaningful use and PQRS team to make sure that they know what's happening. You know, they're aware of your QR/UR reports. They're aware of how well you're doing under these programs, and they understand what you would need to do under QPP. So then you can evaluate financial impact versus the resources that you need to put in, time and effort that you need to put in to succeed under these programs. And then, of course, the marketing impact of this. So, you know, a bad review on a bigger or, you know, more used site where patients come in and review you, that can significantly impact the volume of patients you get. So now this is going to be a website that's published by CMS, by Medicare, that a lot of people are routed to. Maybe that appears or starts showing up on their EOBs. And they go and look at how you're rated, and if you're not rated so well, they might choose to switch over to somebody else. And then there's, over 5 years, there's $100 million in funding as assistance for small practices with MACRA. So Medicare is asking vendors to come forth and provide assistance to practices and providers in implementing health IT technology, in implementing EMRs, and in implementing processes and procedures in place to do well under MACRA and MIPS, to evaluate, you know, how well you're doing right now. Those resources are out there, and if you're motivated, you know, that should be something that you grab and you say, okay, I want to use this because I want to get the most advantage that I can get as early as possible, and I want to be in the top tier, because that's the make or break place. If you're in the top tier, you're going to beat everybody else, you know, to every milestone, to every requirement under MIPS. So that's what we want you to do right now. But very quickly, what are your deadlines? Right? What are the things, and when do you have to do them? So right now, it's been a month since the final rule has been published. All of the, you know, thoughts that we had prior to this final rule, you know, what would eventually happen, what would be the final understanding of how this is going to get implemented, is it going to be delayed a year? We know all of that now. So it's not going to get delayed, it's going to start 1st of next year. We know what we have to do. January 1st on 2017, you need to be collecting information under PQRS measures. You need to be you know, fairly clear about what you're going to do about meaningful use, what you're going to do about the value-based modifier program, and you need to have looked at the improvement activities and there's 90 plus of those as to which ones you want to implement within your practice. So what works for you, what's the best thing for you and your patients. And then if you decide not to proceed on January 1st, then October 1st is the last date that you can start collecting data in order to do the 90-day reporting. And when you choose to do that, again, there is a chance that you get incentive as opposed to just lose the bonus. So that's there, right? So closing thoughts, what we've been repeating often during the webinar, the smart move is to commit to MIPS for the entire year of 2017. Let's say it doesn't go so well, you find out a third into the year, a quarter into the year, 6 months into the year, that is not right. You can make changes, and you can decide, okay, now since the reporting happens March the next year, I'm going to only report for the 90 days that I actually, things are running well, and my mistakes have been corrected, and so this ensures that I'll be successful come 2018. Doing the minimum is probably a very bad idea. It's not only going to hamper you in the first year as to you get no bonuses, but in the next years, everybody else will be better prepared than you. And since we're being compared to everybody else, how well you do or how well they do versus you is what's going to determine, with the bonuses and the penalties and everything that happens from there onwards. So a lot of commercial payers, CMS, or I think this was the Health HHS, which did a survey of half of the health insurance payers in the country. So they included Medicare, Medicaid, all the commercial payers, 50% of them, sorry. And a quarter of all payments based on all of these payers combined are already being made under the alternative payment models in 2016, in this year. So 25% of the total amount of reimbursement that's going out to providers is under alternative payment models. They are projecting that that's going to be half, so half of all reimbursement is going to be under these models by 2020. So this is a couple of years within which you need to prepare and be ready. This might not just be Medicare Part B anymore. This might be every single commercial payer that you work with in a particular area, and the commercial payers are trying to consolidate in themselves, and cost containment is an issue for everybody. So closing thought, this is going to get much bigger than where it is right now, and you should start working on this right away. So CureMD has started a number of programs to help you with MIPS, with MACRA, with alternative care programs, and we're going to provide you a lot more detail as to how that works once we talk about MIPS in our next webinar, alternative payment models in the one that follows after that. We're going to show you what we're doing to help you do a lot of these things yourself, and what we want you to be able to do is to independently calculate what the financial impacts of this is going to be, what the different options are. But if you need help, CureMD has on standby a consultation team. You've probably worked with them in the past. If you've done PQRS, if you've done reporting through the registry, if you've done meaningful use attestations through us. So you can contact us at MIPS@CureMD.com or MACRA@CureMD.com, and we will reach out to you and we'll share information. We will give you the basic guides that we have. Attached to today's webinar is another guide just explaining MACRA in basic detail. So use that, share this with everybody in your practice. It's the time to get on board, to get prepared. This is going to be a much easier transition compared to ICD-10 or meaningful use in its first year. You're already doing a lot of these things. It's just little tweaks and just understanding what works best for you, your practice, and financially as well. So with that, we're going to sign off. I'm sorry this took almost the entire hour and we don't have a lot of time for questions, but we knew we have a lot of content, and that's probably going to continue through our next webinars. So what we'd like you to do is to reach out to us, look at the wiki page within CureMD for more information, send us specific questions about your practice, get on those reports, look at financial reports, look at your QR/UR reports, and understand where you stand today so that you know what you want to do starting next year. It's been great having you. Thank you for joining us. We hope to see you again in the future. And as always, a pleasure. Talk to you again very soon.